Project Director at the Center for Advancing Health Policy and Practice in Boston University School of Public Health. Today, she will present on the data we collected on the medical food and how it has moved the process of our medical food policy, which I'll share with a few slides after her talk. So please join in welcoming me, Meg Comeau. I know she's a very good speaker, and she'll wake us all up in the next 15, 20 minutes.
Is that better? Oh, that is, oh, hi. So I think the next speaker is going to talk about new gene discovery. So that sounds very optimistic to end the day on. I'm afraid that what I have to share today is not quite as optimistic. But there is some stuff in here that I think is good. I want to start by saying a thank you to the organizers of today's meeting for inviting me to share some time with you. It's an honor to present this work. This is the result of work done by my team, and they're amazing. They've assembled a comprehensive overview of state statutes and legislation related to the coverage of dietary treatment of disorders identified through newborn screening. I'd also like to thank Alicia Keene from the National Coordinating Center at the American College of Medical Genetics and Jill Sugar from HRSA's Genetic Services branch for their support of this project, not just their financial support, but their emotional support. It was really important to us. I'd also like to acknowledge the valuable insights and important feedback that we got from members of the Advisory Committee on Heritable Disorders in Newborns and Children. They gave us feedback and advice and help and support throughout the process of this project. We really could not have completed this task. We know some stuff about coverage and financing and insurance, but we're not geneticists. We don't know the genetic components of it. So they really gave very generously of their time and expertise in helping us make sure that what we were saying was accurate in terms of the clinical pieces. So I hope you're all familiar with the Catalyst Center. We're a cooperative agreement. We're funded by the Division of Services for Children with Special Health Needs in the Maternal and Child Health Bureau. We're a multidisciplinary team. We represent a variety of different disciplines. We're based out of the Center for Advancing Health Policy and Practice at the Boston University School of Public Health. We are the National Technical Assistance Center on health insurance coverage and financing policy for children and youth with special health care needs. We provide technical assistance, we conduct research, we create publications, and we connect stakeholders who are interested in trying to improve coverage for folks with special health care needs. This is a screenshot just of the cover of the document I'm going to talk about today. As you all know, medical foods are not those that are simply recommended by a physician as part of an overall diet to manage symptoms or reduce the risk of disease or condition. I have a daughter with a genetic syndrome, and she gets some extra vitamin D and some extra B12 and some extra iron on the recommendation of her physician, but it's not the same category of thing. This dietary supplement, this nutritional supplement selection that she gets is recommended by her physician. It's not prescribed. And nothing really bad is going to happen to her if she doesn't get it. It's there to enhance her health and well-being, but nothing really bad is going to happen if she doesn't get it. Not all foods fed to patients with a disease, including diseases that require dietary management, are medical foods. Instead, medical foods are foods that are specially formulated and processed, as opposed to naturally occurring foodstuffs, for a patient who requires use of the product as a major component of a disease or a condition-specific dietary management. And I learned that from the FDA's frequently asked questions about medical foods from May 2016. It's important for managing the nutritional deficits that impact disease progression. The project that I'm presenting on today, while limited in scope, is a great example of an integration of the activities I described earlier in doing technical assistance, in doing research and policy support, in pulling together stakeholders, and in producing publications. Just about a year ago, we were engaged by the NCC and HRSA to update a 2008 document entitled State Statutes and Regulations on Dietary Treatment of Disorders Identified Through Newborn Screening. As I'm sure you're all aware, adequate coverage and financing for dietary treatments is an ongoing challenge. So I'd like to say a few words now about the limits in scope of the project that I've just referenced. We were not tasked with writing an academic paper or doing original research or of providing an in-depth analysis of the causes and consequences of inadequate funding for dietary treatments or creating recommendations for addressing them. There are already many high-quality contributions to the literature on these topics. We were grateful to have that work to draw upon in our work, and we were hopeful in this project. We basically had two goals. That since the original chart was created in 2008, that new and innovative sources of funding had arisen, and that a comprehensive overview of both existing and new funding sources could aid patients and families and providers in more effectively and efficiently navigating a complex system. So, spoiler alert, we do think that the product, the publication, holds promise for helping navigate the system. We are disappointed to say that there isn't a whole lot new under the sun with regard to funding. We employed a variety of different methods in support of this project. Our team began by completing a comprehensive literature review on the topic of insurance coverage and financing. What are the traditional sources of funding, such as state mandates and the Medicaid program, and were there any new or innovative sources that we could identify? One of the things that we were particularly interested in, and it was trying to find out if the original document was created in 2008, whether the enactment of the Affordable Care Act in 2010 and then the full implementation of the ACA in 2014 had had any real impact on this. And unfortunately, because the ACA did not require medical foods as an essential health benefit, we really haven't seen any big change as a result of the ACA. We didn't see anything bad either, though. We didn't see a mass exodus of funding sources drying up, with the assumption that somebody else is paying for that. We also didn't see any mass repeal of existing state-mandated benefit laws. So on the one hand, not a lot that's new and great, but also not anything that seemed terribly, terribly bad. We then consulted with clinical experts and consumer advocates about what additional categories of information we should consider including in the updated chart. An example of this was elevating WIC funding into its own separate category. Our next step involved reviewing and updating existing state statutes and regulations to ensure that they were current, and then adding newly identified statutes and legislation since 2008 to the state-by-state chart. The authors then researched and added the additional information they could identify per the recommendations of the experts. The original document consisted of a chart of statutes and legislation by state. This 2016 iteration adds an introduction, a method section, a glossary, a list of acronyms, and a summary, along with other descriptive elements to provide additional context to the statutes and legislation in order to try to make the information in the chart more accessible to a wider audience of users. So originally it was just a chart, just columns with legislative language and citations and check marks. So we tried to provide some additional context, to provide some meaning around what those things were, what they meant, and how people could utilize that information. This is an example of one state's chart. I picked North Carolina because we're standing in North Carolina, but there's a state chart for each of the 50 here in this document. I do have to apologize that Puerto Rico and the Virgin Islands were not included. We have all 50 states and the District of Columbia, but I think our next task in updating this will be to add the territories in addition to the states. There is a footer on each page, which I think is really important. It says, state laws and mandates are constantly changing. Please independently confirm the information you find in this resource. We are always grateful to receive corrections and updates, and then our email address is there. One of the concerns that we had in putting this together was trying to ensure that folks weren't going to it and saying, oh, look, there's a state mandate in my state, so this should be covered for my child. We wanted to make sure that people understood the broader context around that. Whoops, I think I went the wrong way. There we go. So while the chart itself can appear pretty technical with a lot of abbreviations and legislative citation numbers, and by the way, all of those legislative citations are active links. When you click on it, it'll go right to the state law, so you can actually see the details. We were able to pull out some high-level observations as a result of getting this big picture overview. Unfortunately, I imagine that what we found will only be confirmation of what you already experience in the field with regard to the challenges facing individuals and families who require dietary treatments and the providers who support and care for them. To start, the summary tables helped us see trends that confirmed some of what we had learned in the literature review. So we looked at a literature review, we learned what had been happening previously, and we compared that with what we were learning about what was happening currently, and it lined up pretty closely. The first table in the document shows that most states offer a broad array of required funding sources through Medicaid, CHIP, and other coverage and services supported by state programs such as Title V. However, as is often the case in healthcare coverage and financing, the devil is in the details. So the depth and the breadth of what's available is highly variable state to state and funding source to funding source. So an individual in one state may have access to what they require, while their neighbor with the exact same needs in the next state over, just over the state line, does not. Two individuals living in the same state, one of whom is enrolled in Medicaid and one of whom has private insurance, often experience similar disparities. So as a result, gaps are common. One of the things that really struck me personally in looking at this topic is that getting these critical services paid for often feels akin to winning the lottery. You have to live in the right state, you have to have the applicable diagnosis, you have to have the right insurance, you have to be the right age, you have to have the right family income in order to get access to something that is fundamental without risking medical debt, bankruptcy, and adverse health outcomes. One clear illustration of this is found in summary table number 2, the list of states that offer coverage under specific categories only as a result of a diagnosis of PKU. So 6 states limit their state-mandated benefit laws in this way. 5 states, Medicaid rules do so. In 2 states, WIC does so. And in 3 states, Title V or other state programs do so. 35 states have legislative mandates for the coverage of medical foods based on genetic inborn errors of metabolism, such as PKU, galactosemia, and maple syrup urine disease. 33 states provide coverage of medical foods through their state Title V, CSHCN, or other programs. So I think sometimes when we think about paying for these services, we only think about insurance, we only think about either a public or a private payer, but there are other state agencies involved that are very important in sort of the web of financing that's available for this service. A word about state-mandated benefits. So I think sometimes people think that all we need to do is get a law in the state that says private insurance companies are required to pay for this. That's what a state-mandated benefit law is. As I noted earlier, the depth and the breadth of these laws varies highly. Some are broad, but many, many more are limited in terms of diagnosis, the services covered, the extent to which it's covered, et cetera. Not every type of private insurance is bound by state mandates. Self-funded or ERISA plans are exempt from state-mandated benefit laws, and there's a high concentration of these types of plans in many states. According to the Kaiser Family Foundation's 2016 Employer Health Benefits Survey, 61% of covered workers are enrolled in a plan that's either partially or fully self-funded. So when you have a state-mandated benefit law, you are getting something for some people, but again, it's not capturing everybody who is in need of the particular service. The language and the vocabulary used in state statutes and legislation is highly variable. So if you look at one state, they're talking about something. In another state, they're talking about the same thing, but they're using very, very different language in many ways. We started to learn that some of these laws were written by politicians, not clinicians. We started to learn a little bit of this from our reviewers, who patiently explained to us such nuances as our not using the terms medical foods and formulas in our written work even though it was used in the statute, because formula in this context is a medical food. So that was really a helpful part of the project that the clinician experts helped add to this. They helped us make sense of the language and the vocabulary that we were seeing in the actual statute. So in summary, there are major inequities in coverage based on the state of residence, based on diagnosis, based on coverage type, whether it's private and public insurance or publicly funded payment sources through state agencies, for example. Those public insurance programs, Medicaid and CHIP, are highly income sensitive, so you can be just over the line in terms of income and not be eligible for a Medicaid program. However, it still doesn't come anywhere near, your family income doesn't come anywhere near the cost of these products. So that was an important part for us to think about as well in terms of income, access to certain kinds of coverage based on income. Age is really important too. So you have folks who turn 18 or who turn 21 or who turn 26, and they age out of their current source of coverage, and therefore sometimes don't have access to a service that they had been receiving. So that's important for us to keep in mind as well. The risks to health status and financial hardship are real and ongoing. I said this wasn't going to be overly cheerful. There's a need for standardization among states and payers. I really think that this is an area in which there's a lot bubbling up. There's a lot of attention being drawn to this topic, especially on the part of HRSA. And I think that's really a helpful thing because, as I said, the risk to health status is huge, but also families are going into debt. They're going bankrupt as a result of having to try themselves to fund this critical service. So the need for standardization among states, among payers, among diagnoses, in order to reduce these inequities, this is really an inequities issue, right? And address their risks is really, I think, important and an area in which folks are spending a lot more time and attention, but there's a lot more progress that needs to be made. So I don't know if any of you are old like me and remember the original Mission Impossible TV show. At the beginning of each episode, the main character would get a mission, and at the end of the assignment, there would be a little disclaimer saying, you know, if you're captured or killed, the secretary will disavow any knowledge of your actions. So this is my disclaimer. The information and content that I just presented is our independent information and content, and should not be inferred as endorsement by our funders or by anyone else. I think we might have a few minutes for questions, but I do want to just put up our contact information. If you have any questions that you want to follow up with us about on this issue or on other coverage and financing issues, we would love to have the opportunity to talk with you. I will say just before we start the question and discussion period, this is another disclaimer. I focus most of my attention on Medicaid policy, so I know why Medicaid does things. I am not a coverage and reimbursement person, so I can't really answer in any depth coverage and coding and reimbursement questions. Not coverage, I'm sorry, I can talk about coverage, but coding and reimbursement questions are kind of outside my area of expertise. So, thank you.